So there's still a line back there getting in, but we'll go ahead and get started. So I'm going to have Dr. Elizabeth David introduce our two speakers this morning and the topic. I think, as all of you know, she is co-director of Faculty Health and Wellbeing in the Department of Surgery, and she does this with Zach Asher. She is really working hard in this space. And I can tell you, one of the things that she has really set her sights on and accomplished is getting a faculty lounge for members of the Department of Surgery, as well as other faculty members in other departments. And she has pushed very hard on this, has mustered a lot of support. And the hospital leadership promises that they will have a faculty lounge in place by mid-2026. So they've drawn out the plans. They're kind of finalizing, exactly what goes into it and exactly what the logistics look like. But that's just one example of the many things that Dr. David does. The other, of course, is to really coordinate all of our work in this space and to make sure that we keep making progress and moving in the same direction. And she was the one who helped organize our two distinguished speakers this morning. And it's about working smarter and being in the right mental spot, which sometimes is hard to do, especially while we're still recovering from a pandemic. Dr. David, thank you.
Thank you, Dr. Schulich. Good morning, everyone. I'm really excited this morning about both of our speakers. Throughout the year, we are going to be having several days where we will be covering well-being topics in grand rounds. And the purpose of that is really to start conversations and increase everyone's awareness of these issues. So this morning, we are so pleased to have Dr. Burden join us this morning. She is currently the division chief for hospital medicine here at the university. She is a professor of medicine and a practicing academic hospitalist. She serves as the deputy editor for the Journal of Internal Medicine. She is a graduate of the University of Oklahoma for both undergraduate and medical school. She completed her residency here at the University of Colorado. She completed an executive MBA in health administration and has a certificate from the Total Worker Health Professional Program. She is the recipient of numerous academic, clinical, service, and leadership awards, both here in Colorado and nationally. Her academic interests include the study of patient and workforce experience in hospitalist medicine and gender disparities in academic medicine. She is a funded investigator on 13 grants. She has published over 77 peer-reviewed manuscripts in addition to numerous work, other publications, and frequent presentations on leadership and her academic work. We are so excited to hear her talk this morning and learn about the science of working smart.
All right, can everyone hear me, hopefully? Let's see. Yes, okay. I'm gonna make sure this works. Great. I may just hop down just to be a little closer to you all. So thank you very much for the invitation. Really thrilled to get to be with colleagues who we would lean on as hospitalists day in and day out. So thank you very much. This morning, this brief period of time together, I hope to cover something that I'm very passionate about, which is how we can build better workplace practices so that we have better outcomes for our patients and our teams. So you got to hear about me, but if I were to summarize it in a nutshell, I think a lot about work design, more than most people probably should, but I'm very passionate about it. I just want to give a quick note of gratitude to a couple of the grants that will support or have supported some of the work that I'll share, though didn't influence it. So I hope to do three things today. I want to explore the concept of clinical operations science, something that you may or may not be aware of. We'll look at a framework around designing and implementing effective workplace practices. And we'll think about leveraging data that we have today to build a better future of work. So I wanted to start off with the multi-million-dollar problem. And in fact, it's also probably quite larger than that. But what this number means is a little bit context dependent. But imagine being a clinician leader and you need to build a service. And you think maybe it's a bunch of services. You need $12 million. But your counterpart in the same room is like, I think you need 11. Do you need 12 or do you need 11? And in those rooms that are often high tension, there are different mental models around what you need. A clinician may think, I need lower workloads. The administrative partner may think, I don't have that much money. So who's right? So we're going to talk about this throughout our time together, the multi-million-dollar problem. So I think about this problem a lot. It drove me to business school eventually, after having enough of these high tension meetings, thinking about what is optimal. And it got me to this fundamental point that I feel like I can confidently say, which is when we treat people as a line item with inaccurate accounting, we cause harm. It actually costs our organizations a lot of money because we don't get it right on the front end. It costs us in injuries to patients. It costs us in injuries to our workforce who eventually leave. And in the end, it costs our organizations lots of dollars. So how can we start to get this right? So we'll talk about a concept called clinical operations science. So I only know a handful of you in this room, but I want to see by a raise of hands, how many of you use evidence-based practices when you're working? Every single one of you, right? I assume that, not knowing all of you, but as clinicians, we have an abundance of evidence, more articles, more guidelines than we can even keep track of. But we know which antibiotic to pick, which procedure this patient needs at that moment in time. We have guidance. But what about in the work design world? How many of you have seen the evidence around optimal clinic structure for how many patients you should see in clinic? Anybody have evidence around that? Hand of one. What about OR scheduling? What about how many patients you see in the hospital? Have you implemented that evidence? Does it exist? I would argue it doesn't yet. So my first foray into clinical operations science happened almost 2 decades ago when I first started my job at a safety net hospital. Well, we had no money, we had a lot of passion. And my boss and mentor at the time believed that we would have an academic hospitals group, which was pretty profound if you think about almost 20 years ago. And he expected that we would meet with him every single month. I was terrified of him at the time. He would grow to be my mentor for my entire career and still is actually to this day. But he expected us to have scholarship. I was not a researcher. I was not a scholar at that point in time. So as I desperately tried to find a topic so that I didn't get fired, I scrounged around for a good 1.5 years. And then what would happen in the United Kingdom, they would implement something called bare below the elbows policy, which meant that you weren't allowed to wear a white coat, you couldn't wear jewelry, and the whole thought was you could prevent bacterial contamination to patients. An entire country rolled this policy out. And you can imagine that there was a little bit of uproar because there was not quite evidence for whether this policy worked or not. So I found my idea. I finally got it past my mentor after having numerous fails. And we would conduct a randomized controlled trial. I had less than $300. It bought me the agar plates. I befriended the laundry folks. I befriended the micro lab and got a lot of great colleagues to help me culture people. And what we found is at the end of an 8-hour workday, not surprisingly, there was no statistically significant difference between white coats, which you can imagine were slightly dirty, people don't wash them, compared to the newly washed uniform, which we checked in the morning that had no bacterial contamination. There was no difference. So I call this study the little study that could, because it ignited a fire in me, because I thought if this is all it takes to get the Canadian press and the Wall Street Journal to listen to me about a study, game on, world. So then I had several studies after that. But I started thinking about, we implement a lot of interesting things in our organizations and even across our countries, similar to the bare below the elbows policy, that we may not know if they actually work. Now, I entered leadership very early in my hospitalist trajectory, like almost within 2 weeks of starting my first job. And so I was a young leader who did some silly things along the way. But no matter which hospital you work at, across the United States, and I would even argue now globally based on feedback on this article that I'm about to share with you, we do interesting things to try to improve throughput. And one of those interesting things, at least in my career, is to text busy clinicians to remind them that it's really busy today. And if you forgot since yesterday, you're supposed to prioritize the discharging patients first. As a leader, I sent those texts. At some point, though, you start to grow older and wiser, and you start to question whether this is actually the most effective use of your time or the clinician's time who are actually taking care of patients and know very well that it's busy. So I was able to get funding from AHRQ to do a randomized controlled trial across 3 hospitals to look at, does prioritizing discharging patients first as a sole strategy, does it actually improve throughput or length of stay? And what we found, no matter how you sliced and diced the data, it didn't change things. No difference. But what we did find in the qualitative data is that perhaps this effort as a sole strategy might even cause harm. So you can see in the top right, irritated that I had to go see these patients first when I knew that it was going to cause rework. The strategy is rolled out across hospitals across the entire globe. So why does clinical operations science matter to every single person in this room, to every single patient, and to every single organization? I would argue that it matters more than ever. And it matters more because there are interesting things, interesting dynamics going on in our organizations across the country, even world. And when you talk to the frontline workforce, so I'm a workforce researcher, I talk to thousands of people, it seems like, leaders, frontline clinicians at hospitals across the country and even beyond. What I hear in the research is people feel that there are conflicting goals. They feel that sometimes it feels like a profit over people mentality. Unfortunately, we have limited resources. I think that is not going to change. And then we also have uncertainty around our organizational decision-making. As a hospitalist, I'm not even sure what the volumes are going to be next year, yet I'm already hiring for next year. So there's a lot of uncertainty. And then when you have this trio of conflicting goals, limited resources, and uncertainty, we make decisions often out of scarcity. Adding further injury to insult or insult to injury, there are interesting articles, and you don't actually have to read the literature to understand this, but interesting articles that highlight the turmoil that we face in trying to provide best care to our patients. This top right highlights that if you're in primary care and you try to follow the evidence, the guidelines, you have an impossible job because it would take you more than 24 hours to do in a day. Bottom left, it says that if you're doing care in the inpatient setting, patients continue to get sicker. Yet when I look over the last almost 2 decades of my career, our staffing models haven't really changed. And then the real threat to the viability of our organizations and to healthcare at large is that when you look at the healthcare workforce, it's a burnt out workforce, and people state they don't intend to stay in it, a high fraction of people. So in my workforce research, I get to talk to a lot of people. In this study, I got to talk to people from 32 different organizations, and I think it highlights the feelings of the frontline workforce and leaders. They were also in this study. We asked the following 3 questions. My healthcare organization prioritizes clinician health and safety. 6% said to a great extent. My organization encourages transparency and accountability in decision-making, 9%. I have witnessed instances where administrative harm, this means organizational decision-making, I'll talk more about it in a minute, has led to adverse patient outcomes in my healthcare setting, 85%, sometimes to a great extent. As far as I'm concerned, that is an F rating. And these are organizations who are supposed to care about people, about caring for patients, and about caring for the people who care for those patients. So now we're going to get into the hopeful part of all of this. You got to hear a little bit about current state and why clinical operations science is so important. So now we're going to explore a framework for designing and implementing effective workplace practices. So as an organizational leader, as leaders in this room, as far as I'm concerned, every single person in this room is a leader, maybe informal or formal. We lead teams, we lead groups of people. When we try to focus in on improving things such as patient care, burnout, financials, if we only focus on the right side of the equation, we're never going to get there. We have to think about the left side, which is work models and work environments, work processes drive these work outcomes. And if we don't think about the left side of the equation, we'll never get to the right. It gets at this concept of the Starling curve, which some of you may be closer to reading about the Starling curve than I have been for some time. But it's an important concept in work design. We think that we can just constantly do more, take on more, not sleep, but we can't. We're humans. Maybe AI will help with this. But there are breaking points at which we stop to provide the best care possible, at which we stop wanting to actually provide care. If you look at the literature in the nursing world, they have more than we do in the physician world. But what you see is that when you increase the workloads of nurses, patients die, nurses are burnt out, and they are dissatisfied with their job. In the hospitalist world, all we think about, it seems like, is throughput and length of stay so we can get more patients in. But there's a breaking point at which if you see more than X number of patients, your length of stay starts to go exponentially up. But how many length of stay efforts do we ever think about, oh, I wonder what the work design is. I wonder what the workload is. And it costs organizations money. I went diving deep into the surgical literature too. It turns out you're also impacted by this. There are thresholds and amounts of sleep that as humans we need to perform well. When you look at workloads and perception of safety culture, that's impacted as well. And then this is not an aha moment at all, but workloads also impact the safety and well-being of our workforce. So if you take one thing away from our brief time together, is that not getting work design correct equals harm. Equals harm to patients, our team here, and our organization. So how can we start to implement science and think about this from the perspective of optimal work design? So we have a lot of tools in our toolbox, and I could go on for hours on this, but we don't have to wait a decade to figure out what optimal is. And here's just a few of the different things that we utilize, my research team. It's not just me doing this research, but we use rapid qualitative methods, quantitative, qualitative, you name it. And we do rapid turnaround research to try to get at what optimal is because we don't have time to waste. One area where I've taken a very deep dive, because as hospitalists, the question is always like, why can't you just see 20 patients? Why can't you just see 22? Why not 30? Because it'll help the bottom line. Does it though? So we started thinking about what are the measures when we think about workload? Is it work RVUs and encounters, or is there something more? How do we collect the data, and what are the outcomes? And we really just took a deep dive, scoping review, and this was more in the internal medicine sort of sector, over 6,000 articles, none of which really had the magic sort of bullet of like, this is what you have to do. Nobody has the answer yet. We did a Delphi panel where we looked and talked with experts around the country, administrative, clinical leaders, business leaders, researchers, and not surprisingly, we didn't just find two things, work RVUs and encounters. We found a much broader perspective of how we have to start thinking about workload and work design. And the goal is to really get to a concept that I call evidence-based work design, very similar to what we do every single day in our clinical care. So how can we start to think about leveraging data so that we can get to optimal? And I think about this as kind of like a Moneyball for medicine approach. Taking data-driven decisions. So we can passively acquire data, which I'll share with you in a moment, very strategically, actively acquire data to try to get at this concept of evidence-based work design. We built an app. It's called Gritty Work. If you're interested, you can see our work on grittywork.org. We welcome you to join the work. I would love to understand the surgical world, the outpatient world, and so much more. We started in the inpatient space because that's the world in which I live. But we ask our clinicians very strategically, what's your cognitive load? What does this service look like compared to that service? And we're about to roll this out division-wide so that we can sort of hotspot it. Which is the service that's not working well? What can we do to optimize it in a very broad sort of way? This is really cool. This is audit log data or event log data. I don't know if you all have heard of it, but it is an Epic, and there's a bunch of different versions. There's Epic Signal, so aggregated data that I can go in right now, and I'm not a data person, go in and see patterns like this on my clinical team. I don't have to ask a clinician to do anything. All of our clickstream data, everything we do in the electronic health record is captured. So when you implement a new care model, you can actually go in, look at the signal data. If you want a data scientist, you can also look at the deep dive, unaggregated data, but we can start to see what the patterns look like. This is what a hospitalist one looks like. You can tell we round between 8 and 10, and then we also work into the evening hours when we spy on our patients to make sure everything is going okay. I'm sure everybody in this room loves secure chat, but all of it is captured now as well, so we can get a much broader view of what workload looks like. What we found on our clinical teams is our teams on average are getting and receiving, sending 130 messages per day. This is just a day shift. And our response time is in the realm of seconds. And even as workload goes up, we might have a few seconds more, but it's pretty fast. And so we have to start thinking about interruptions and how do we optimally communicate. I think there's a lot of potential in secure chat, but there's a lot of potential for harm if we're not thoughtful about how we think about how we use it. So the dream is really to use the mobile application very thoughtfully, to use all of this electronic health record data that exists right now. We can go in and grab it today and start to then aggregate and bring that data together to start to connect work structure to actual outcomes. Does a service lead to burnout? Does a service lead to length of stay issues? Does it lead to financial harm? And looking at it from a multi-stakeholder perspective. Now, the cool thing about this work is that I think work design is going to change now more than ever. It felt like over 10 or 15 years of my career, it didn't really change, but it's changing rapidly. And there are now virtual AI scribes, which is going to change the way we work. There's going to be assistance with our diagnosis. So lots of, I think, new innovation is coming. But the one risk in all of this is that the thought will be you can just always do more higher cognitive load work. And at what point do you start making worse decisions? So understanding a framework for how we think about how we implement these new technologies will be critical to making sure we don't cause further harm. This is the last little bit here, and then I'll conclude. I want to think about organizational decision-making. I entered leadership as a young leader. I made bad decisions. I didn't really thoughtfully look back at those decisions. And I think that is a common thing that happens across healthcare, young or not. And I got interested in this concept of administrative harm, which means administrative decision-making, which can come from clinicians and administrators alike, that leads to hurting people. And we often get distanced from those decisions. So when you make those decisions, you may not know that it led to a patient dying because the clinician didn't have enough bandwidth to actually think about that person. So we have to start thinking about our administrative decisions much in the way that we do for our clinical decision-making. You can go to JAMA Internal Medicine and take a look at this article. It was qualitative, 32 organizations, broad strokes. Everyone sees it and recognizes it. They just didn't know the term for it. The higher up you get, the more distance you get from your decisions. And then people also are afraid of you. So you have to start to think about how do you build psychologically safe culture so that when you institute something and a frontline worker knows it's not right, that they are brave enough to actually tell you you didn't get it right. And ideally, there's rapid iterative cycles of you implement, you get feedback, and you do better because we're not perfect and we don't always get it right. And this really gets me to the final concept of a learning health system approach, which is when we implement things, we have to study them, we have to get feedback, we have to have cultures that support feedback in friendly ways so that we can constantly make our work better for better care. And hopefully for a workforce that wants to stay here. And I believe that if we institute this and are very thoughtful here about the University of Colorado, we can be the best organization in the country, if not world. So what does success look like? It's a shared understanding of what our decisions mean. It means that we understand when we say you only need $11 million versus $12 million, or why can't you just see 22 patients? Now we'll know what 22 patients might mean. We have to build trust and transparency. If you don't have it, you're never going to get feedback. And then very outcomes driven, but it can't only be financials, because I hope that I've shared with you that it actually impacts financials when people don't stay, when patients die, and when throughput suffers. So thank you for your time. I'm really thrilled to get to spend this morning with you. And here's my contact information if you have any questions or want to partner.
Have a couple of minutes for some questions, if there are any. I'll start, or go ahead, Dr. Schulich.
Thank you so much for doing this. this is such a target-rich environment in the hospital. What I found is a problem is, if you look around, there are 1,000 things that need to be fixed. And we don't focus in general on the three that will have the largest impact, and that, there are things that we can actually do if we get people organized. How do you get your team to focus on, just a few issues at a time rather than trying to boil the ocean?
Yeah, we probably do try to boil the ocean somewhat because everybody's got their passion. But I think where we start when we don't know where to start, so I use something called rapid qualitative methods, which is you do focus groups, get a pulse on the team, you also have data, and then kind of hotspot it from there. In the hospitalist world, if you were to ask probably any hospitalist, workload is always like top of mind. And so that one's almost like an easy target. Like, is it fostering good care? But I think using these methods that I shared, rapid qualitative methods, we have this like app now where you can give really quick feedback. And then me as a leader, I don't actually see where it comes from. I have a data team who disguises it all. So it's very safe. So if I did bad on some decision, they'll be like, Marisha, you could have done better. I don't even know where it comes from. But that's just one, I think, arena. And then we have a very large team with a lot of passionate people. And so in some ways we can kind of boil the ocean because we have so many people dedicated to different things. So.
I have one more question for you. In thinking about workflow, for surgeons, we have, our two primary interactions with patients in the clinic and then in the OR. If we're going to model something for OR efficiency, how do you account for the variability between surgeons? Surgeon X takes 30 minutes to do a gallbladder, surgeon Y takes 90 minutes. How do you model that and build that into these models?
Yeah, that's a really great question. And I think a very tough question. So where we're starting with the work is at a very high level, systems level approach, like let's get it right there first. And then we'll start to deal with individual variation. There are actually really interesting programs though that you can, they're very expensive, but I think we can also do it here where you can, as a provider, see what your data is compared to your peers. And so there's some mechanisms for peer comparison. We haven't cracked the variability, not yet, but really at a high level, I think is where we're starting is what is foundational for all people. Mm-hmm. And then where is deviation like not good and where is deviation okay? So I don't know that I have an answer for you just yet on that one.
Yeah, because I worry if you are comparing between surgeons, it sets up competition, which I think is not the best in terms of thinking about well-being and throughput. But I think, all of us would love it if the OR in general could be more efficient, and we are part of the OR being more efficient. So
yeah. And I think taking that, like it's a systems level issue first and foremost. I feel like we get to hire amazing people here. So it's rarely a people problem and usually an organizational, like how did we structure it so that you can succeed?
Fascinating.
Dr. Burden, thank you for your presentation. I know you must have some data comparing nighttime hospitalists to daytime hospitalists. And what do those data tell you about the difference between the time of day that people work?
Yeah, that's a really tough question. So we're about to roll Gritty Work out to our entire division to kind of understand what's the cognitive load like at night, what's the cognitive load during the day. But the tricky thing to compare day and nights is that the roles are just so different. So you're usually not discharging patients. You're doing a ton of cross cover. So I think understanding comparisons of day and night may be hard. So I'm not sure I have like a comparison just yet. But our goal with the Gritty Work effort and just sort of optimal work design is to understand, for example, sometimes our folks will cross cover on 80, 90 patients and that's their sole job. But when is it too much, And night coverage is very expensive because a lot of people, it's not their favorite shift. So you have to have shift differentials and salary differentials for that type of work. So really trying to get it right where you can find people who love the work because not everybody does. And then setting them up for success. So we don't have comparisons yet. And I think the comparator will be hard because the work is just so different.
Thank you so much. This was really fascinating.